All right. Hello, everyone. Welcome back to VMR. We've had, almost a week off, so it's so wonderful to be back and see everyone's faces. It's really, really wonderful to see everyone. So today I am discussing with Rabih, and I will just open it up to the crowd to see if anyone has a case that they would like to present for this 30-minute VMR.
I told you.
Can. Oh, you have a case. Amazing. Do you want to unmute? I've actually heard, Steve, I've heard your voice on RLR solvers, but do you mind just unmuting and introducing yourself to everyone here?
Yeah, sure. Just been a pleasure. I promise this is not going to be a functional neurological disorder. I'm sorry for the teaser for those who haven't
Yeah,
watched.
You could have spoiled it for those who didn't listen to it yet.
I'm sorry. But my name is Jazz. Full name is Jazz Deep, but Jazz is fine. I'm a family medicine chief resident at the University of Rochester. Fell in love with Rabih and Reza and the whole CP solvers ever since I was an intern. So I haven't really known anything else ever since. So my poor wife has to listen. She's not in medicine. She has to listen to hours and hours of Rabih and Reza's voice and all of yours. So a little nervous, as you guys can tell, but if it's okay, I do have a 30-minute case that I feel like people would enjoy. I'm just seeing
Jazz.
I'm just seeing all the love in the chat. I really appreciate it. This means a lot. So
yeah, thank you so much for presenting the case and for being here. I listened to both of your cases on RLR CP solvers and was just kind of blown away by how structured it was and just all the learning points at the end. So really excited for the case this time.
Jazz, what's up?
It's a long time no see.
I know, right? Why are you nervous?
Just because there's like 19 people on board and
last
time it was the three of us, and
I know
the fact I see recording in the top left corner.
I know, right? 100%. I'll add to that Maddie is here, and Maddie is a sharpshooter discussant. So yeah, you got to be intimidated a little bit. I'm kidding. No, you should sit back, relax. This is a friendly crowd. I think I've met everybody here, which is really, really cool. I encourage all of you to share your thoughts and opinions in the chat, because I think it really is a small crowd and we should totally take advantage of that. But yes, it is a 30-minute case, so I will shut up and pass the mic to you, Jess, to take it away.
All right. So this unfortunately won't be as structured as my other case, just because it was kind of last minute decision. This is a patient that I see in clinic that I felt was had a pretty interesting history. So I'm gonna start off vague, so that way you guys can both discuss it. So this is a 49-year-old female that presented to the ED with seizures. Generalized tonic clonic seizures. Do you want me to get that, or do you want me to stop there?
Let's see. Do you want to give us a little bit? Actually, we can just pause here. We can do kind of a quick approach to it, and then you can give us more information. Is that all right, Jazz?
Yes. That's
all right. Okay, perfect. So we have a 49-year-old female presenting with generalized tonic-clonic seizures. So what's interesting about the chief concern or the presenting sign of seizures is you can kind of take it a few different ways. You could take it one as, accepting that this is a generalized tonic-clonic seizure and going through the differential for that. Or you can instead, think of mimickers for seizures, and instead, when you hear seizure, convert that in your mind to, transient loss of consciousness or transient neurologic syndrome, because there are a lot of things that can maybe appear like a seizure, but maybe in fact is not exactly a seizure. So for example, for the transient loss of consciousness, there are the various S's. So syncope can often manifest as a seizure. Stroke or TIA can manifest as a seizure. Hypoglycemia can manifest as a seizure. So I think before, we just accept that this is a seizure, we want to step back and really think of the mimickers. And I think some important things you would want to ask and ways you can make progress on the different mimickers is what happened before this, apparent seizure, during and after. So for example, for syncope, was did the patient feel lightheaded? Were there any, tongue lacerations, which would point to a seizure? Was there any kind of focal neurologic deficit that would make you point more towards a stroke? So really, I think the summary here is that you want to take a step back and think of some of the mimickers in the history, ask about kind of what was the patient feeling before, during, and after, and then we can kind of go forward with how you make progress from there. But that's kind of what's going through my mind. Rabih, do you have anything to add about initially?
No, not at all. I think it's so important in this situation to emphasize what you just did, which is that you don't know this patient is seizing until you've seen an EEG. And the closer the pattern of movements is to a seizure, the more confident you are, but you're never really 100% sure. So you're kind of have one foot in both directions. Is it a seizure, and what does that mean? Or is it a mimic, and what does that mean? And you don't commit to either one of them until you actually try to witness the event and or clarify the things around it, be it in the past, a history of seizure, or in the future, a tongue laceration. Practically speaking, I think the most important thing in the circumstances is to immediately get out your phone and record the movements. A lot of people worry about HIPAA compliance, and I think that's an important thing to hold in the back of your mind, though the value of the data that you can have is in most circumstances outweighs any issues with HIPAA compliance. So for me, and in the circumstances that I practice medicine, what I would do in the situation is immediately start to record visually what's happening to be able to study it in more closer detail. And then practically speaking, you want to get a finger stick glucose right away. So it's like, for me, it's camera, glucose, and then order the benzodiazepine. The good news is that over 90% of generalized tonic-clonic seizures will terminate in less than 2 minutes. 90%. So you probably won't need that benzo, but you don't want to order it when you think you need it, because it'll take a few more minutes to get there. And Umaima is sharing a really powerful point. I think that that you don't have to be the person recording, that anybody around, including family members, can record. Awesome. All right, Jess, back to you.
Awesome. Maddie, that was such a great discussion. Thank you. So more history on her. So she has a past medical history of right-sided MCA stroke. She has also had a CSF leak back in 2001 in the setting of a pseudotumor cerebri. And like I said, she presented to the ED with sudden onset generalized tonic-clonic seizures that did not really improve with Ativan and needed to get phenobarbital. She was also very disoriented, confused before. So she was brought in by her family member, and the family member said she was fine. She went to get a CT myelogram done, and basically was found to be doing okay. She went to go pick her up, and when she came, when they were just about to arrive home, she kind of got disoriented, went into a seizure. And when she woke up from the seizure, she did not recognize me. I rounded on her in the hospital, and she was not able to recognize me. She was not able to recognize her family members. And she did spike a low-grade fever about 8 hours after her seizures resolved. Her initial blood work showed a mild leukocytosis of 13.3. She had a mild neutrophilic and lymphocytic predominance, so 6.4 for neutrophils and 5.5 for lymphocytes. She also was slightly hypernatremic at 148 with a mild elevated potassium of 5.3, and the rest of her labs were within normal limits. Yes, I can repeat the CBC again. 13.3 was the white count. Hemoglobin hematocrit was normal. And then the differential was neutrophils of 6.4 and lymphocytes of 5.5. And
Oh, right. Oh, go ahead. Sorry.
sorry. For the reason for the CT myelogram was she's had like worse progressive low back pain that I was managing in the outpatient setting in the last like 3-4 months.
All right. Jazz, this is a lot of really interesting data here. So I'm just going to kind of go through, the information you listed and call out some things that jumped out to me. So, the first aliquot, you said that this is a 49-year-old woman coming in with generalized tonic clonic seizures, and then you mentioned this history of a right-sided stroke. And to me, immediately what jumped out is, could the present seizure be related to that stroke? Because we know that prior strokes can be, a foci of new onset seizures. So that I'm just wondering if that, the current seizure was potentially related to the past stroke. It's surprising that it didn't improve with Ativan. So I think that might be, I'm not sure how exactly to put that together, but the fact, I'm sure there's a whole differential diagnosis for seizures that don't improve with benzos. So that stood out to me. So then you mentioned that the patient was altered. So, it seems like we had this seizure and then an altered mental status. And I'm trying to understand the time course here. Jazz, I'm wondering if you could, was the altered mental status, was this acute or that been going on for some time?
Hyperacute.
Hyperacute. Okay. So that is really helpful, because when you're thinking of altered mental status, the time course is really essential. And we talk about the MIST mnemonic for altered mental status, metabolic, infection, structural, toxin. And within, infections, you can think, is it, within the brain or outside of the brain? And I think the fact that this person has had seizures and has had this history of brain issues, stroke, CSF leak, I'm concerned that the brain is at risk for, potentially an infection on top of this. And that's kind of compounded by, I think you mentioned that there's fevers and then a leukocytosis. So I think all of this to say is that you mentioned some signs that this person is inflamed with the fever and with the leukocytosis. With the past medical history and with the seizure, I'm concerned that there's some localization to the brain here. But at the end, you mentioned this back pain. So I'm also, I'm not incorporating that yet, but that's just something I'm tracking here, because back pain, we think of like red flags and things like that. And there are some red flags here, including a fever. So I think I'm just noting the back pain, not really incorporating that yet. But that's where I'm at. Rabih, I'm curious how you're putting all of this together and like what you make of the past medical history and if it's currently related to the presentation.
It's really tricky, right? I think, you're getting more and more confidence that this patient's seized by the fact that it was so closely observed, and that you're finding so many reasons for a seizure to be plausible based on the risk factors that she has for them. And I think that the tricky part of this is we would accept that the chronic things that she has, a CSF leak, pseudotumor cerebri, and a right MCA stroke, are all sufficient explanations for her to seize. But you have to be open to the probability that a seizure may be reflective of an underlying dynamic and active neurological issue. And that's the tricky part with seizure, is you can have a discharge of neurological activity from a chronic issue like a traumatic encephalopathy or a stroke, or you can have an ongoing neurological disease be the reason that you are seizing right now. And just because she has structural brain issue does not make her immune to having an ongoing dynamic and evolving disease process. And I think how do you decide between the two? Well, you have to assume the most morbid scenario, which is that she has something that is progressive and ongoing. And that assumption is starting there is wise, and continuing, it gains momentum by the fact that she remains altered despite treatment for the seizures, and her seizures are requiring a lot more than people usually require to break through a seizure. And in fact, she might be transitioning into non-convulsive status epilepticus. And that should have your default assumption be that there's a dynamic neurological disorder. And that eventually takes us to the world of MIST, metabolic, infection, structural, and toxin, where you're at. And so immediately you start to simplify this problem and say, that I'm solving acute altered mental status complicated by seizures and maybe status epilepticus, as opposed to anything else. And you might be solving the wrong problem. It might turn out that she just has a seizure from her prior injuries, but you cannot assume that. So you should assume she has an acute neurological issue, and that's why she's seizing. And so then it becomes the exercise of, well, what are the flags for missed? And the flags are that she has some metabolic issues. She's hypernatremic, but that's not enough to cause a seizure. She might be infected based on the neutrophilia and the fever. And the question is, where does that infection lead take us? It takes us to the usual places that people get infected, but the problem is that it might be a distractor, because it's so common for people to seize, aspirate, have an aspiration pneumonia, pneumonitis, and cause a fever and a white count. And that's just unrelated to the actual initial event. However, in somebody who's had back pain, who's had a CT myelogram, you have to worry about a pyogenic meningoencephalitis. Because the way a CT myelogram works is that you take a needle, you access the CSF space, you inject contrast via an LP. And so it's very plausible that someone who gets so sick after this procedure has had a complication from it. And the complications may be an infection, or the complications may be CSF or brain herniation from this procedure. So there's also, by the way, just because we're super esoteric here, there's also a rare complication of the contrast. You can get contrast encephalopathy from the dye that is given during this. So there's a lot of esoteria and a lot of practical things. I'm just going to summarize because I can tell this case is actually complicated to solve. You have a seizure for sure. The seizure can be a manifestation of chronic scars, stroke, the pseudotumor, but it can be because of a new process. Without knowing anything more, you should assume it's a new process that equals missed. But there's much more than just the base rate that tells you to assume it's new. It's not getting better. It's refractory to treatment, and there's a lot of signal that there's something bad going on. Caveat, the signal could all be a consequence of the seizure, aspiration, pneumonia, pneumonitis, but that is an assumption you should not make. And in the context of what just happened to her, her CSF space was accessed. She could be infected, she could have herniation, or she could have a rare contrast reaction. Now that I've rambled for this long, Maddie, any other thoughts come to your mind or questions pop up for you?
Yeah, I think it was helpful for you to walk through kind of how the CT myelogram works. I didn't exactly know, and I think that definitely brings in the possibility of infection, as you said. So I'm wondering at this point, are you thinking next steps would be imaging, and would you be imaging? But yeah, I guess how would you move forward from here? I'm thinking, would you image the head, or would you get a CT scan of kind of where the CT, like where the injection was and where the back pain was? Like what thread would you kind of go down?
Yeah, I think you definitely need to take a picture to get a CT scan very quickly in this patient. And then you might have to do a lumbar puncture. Yeah.
Yeah.
So. Yeah. All right. Jazz, tell us more, please.
All right. I'm getting like a lot of messages in the chat, so this is great. I just wanted to answer one of the questions. One of the questions was, when did she get the CT myelogram? It was basically about a few hours before she started having the symptoms. So I think you both Maddie and Rabih, you guys did like an excellent discussion of the presentation. Again, I didn't do the greatest job of presenting this just because it was last minute. Vitals were, I kind of sent the message to Sammy about the vitals, but the rest of the exam, other than her being disoriented, was all within normal limits. It was not contributed to the case. If I'm allowed to share my screen, I do have some CT images that I wanted to share.
Ready for you.
Yep. So can everyone see this?
Yes, so you can see it.
Okay, let me scroll through the images here. And this is essentially the last aliquot. I'll give you guys more like a course of the history. So she was put on Keppra after the CT scan and stabilized quite well. And basically her disorientation essentially came back to baseline. It took a few days. Someone said I have no idea about the radiology. I agree. And Robbie's probably thinking that all I'm going to do is present neural cases. This was a pure coincidence. So I'll stop there for you guys to discuss.
All right, so we may have to pull back up those images to get a closer look. But you know, some of the things that I was looking out for are, you know, is there some obvious space occupying lesion? I did not see that. I'm looking to see if there's, you know, any enlargement of ventricles, any hydrocephalus. That's not something I see as well. So if you go to the top one, Jazz, I mean, the takeaway here is I'm not exactly sure, but I'm going to try my best to kind of walk through some things. So what's interesting here is you kind of, on the left side, you see more of like the contours of the brain parenchyma versus on the right side, you don't see that as much. Yeah, as Ravi said, the sulci are exaggerated on the left side. So that's what's standing out to me. I'm not exactly sure what that could represent, but there is this abnormality between the two hemispheres. Yeah, I think, Robbie, you put it really well in the chat. Like the sulci do seem to be exaggerated in that first image. It seems like more so on one side than on the other. I'm getting some good hints into like, could this be, is there a bleed here? I'm not exactly sure, but yeah, Robbie, what's standing out to you about this imaging?
Gosh, I wish I'd gotten a residency in neurology just to be ready for that cases. I love this. I think it is a really educational case, and I think I just got to say I don't really know what's going on, but I think it is really helpful probably for all of us to compare and contrast what a normal CT scan would look like. And Manny, do you want to try to pull that up, like just to refresh
a normal CT scan?
Yeah, just try to pull up a normal CT scan, and you can share your screen just to be able to compare it, because I think oh, thank you. I think Omama might be okay. Never mind. Perfect. Thank you, Omama. Yeah, I think let's just study the other dimension we have, which is that the patient was really, really sick for a while, but with control of the seizure, Keppra, she gets better, right? So one other way of studying the landscape of what's going on is the data that you're trying to get about the syndrome, but also its behavior over time as you treat it. And I'll just keep talking until you find one. That's perfect, Maddie. So like that's a normal scan, right? Although I have that scan, it's amazing how you get used to patients with maybe older age, those ventricles look compressed, but actually that's a very normal CT scan that you have. So we'll loop in the CT scan in a sec, Maddie, but let's talk about the stuff that we're probably a little bit more comfortable with, which is the non-radiology. So we have this patient, she has a seizure, she gets Keppra, and she gets better. So if we start to analyze the initial schema. The initial schema is this seizure secondary to an old scar, or is this seizure secondary to a dynamic process? How does the fact that she gets better with Keppra help you in that analysis? Like, how would you dissect that dimension of it?
Yeah, let me think about this. So you're asking, like, the fact that she responds to Keppra, does that point more towards it being a new dynamic process, or like as a result of the old scar?
Yeah. What do you think about that?
I think I'm leaning towards it being more like a new dynamic process. I actually really don't know.
I admire your caution, and I think you should be. So I don't know. If you just say, hey, somebody seized, they could have seized from an old process or a new process. I just treated their seizure and everything got better. Then you would be like, wait, hold on. If you just treated the seizure, well, why did the new process stop? Why didn't it take off? Right?
Mhm.
Fair, are you like, for just to be concrete, you're having a new seizure because you now have a UTI on top
Okay.
of your other stuff. You just give the patient Keppra and don't give them antibiotics for the UTI. Why would they stop seizing? Why would they not have an ongoing
Right.
problem in some way, shape, or form? Right?
Right. Right. Right.
Fair. So
Right.
if
Yeah.
you,
So yeah.
yeah, if you're sticking with that overall landscape, you're like seizure secondary to old problem or new problem. If you just give seizure medications on a simple level, you're like, well, the new problem is either really mild or it was an old problem. Fair?
Yeah. Yeah. Yeah.
It's a trap. So here's the trap. We're assuming that the new problem isn't transient, that isn't something that spontaneously would have resolved by itself anyway, right? So if something is new and dynamic, does not mean that it lives on forever and that it requires treatment to improve. So I will say this. I think we're anchored in a seizure for sure. And the question is an old process or a new dynamic process? And I think if we're trying to be logical with our reasoning, we will say a response to Keppra alone would so strongly support a static old chronic problem. However, since she was treated not just with Keppra, but treated with time as well, that a spontaneously improving but new and dynamic process is still in the DDX. So could she have had pyogenic bacterial problem from this CT myelogram? No chance. Could she have had herniation from this myelogram? No chance. Could she have had a contrast reaction? Very possible. So what you're seeing on the CT scan, her CT scan, which is so different than the normal CT scan, the normal CT scan, is that she has the contrast that was given percolating in her brain. That's why you see it in the sulci. Because remember, if it's injected in the CSF space, it's contiguous with the whole brain. So it's lighting up her ventricles and it's lighting up the outer parts of her brain. And so I think that in this patient, I don't know enough to be confident, but I would say, hey, I'm really glad she's better. It could have been the old MCA stroke, but the timing in relation to the CT myelogram is a powerful clue here. The only complication that I know of that is self-resolving is contrast encephalopathy. It's probably very unusual for her to have an infection that self-resolves. It's unusual for herniation to self-resolve. But contrast-induced encephalopathy is a fascinating condition that occurs with any kind of contrast, any kind of iodinated contrast, be it CT or fluoroscopy, which is probably what she got. So that's probably what I would be thinking of. But the truth is, it doesn't matter. She's better, and I'm glad it's not in meningitis or herniation. But that'd be where my instincts land. I'm curious what you're thinking now.
Yeah, that makes sense to me. I think when you were asking the question, more new dynamic process or older process, one of the reasons I was stuck is I was thinking, Jez, I don't know if you give us how long ago the stroke was, but I think I was just thinking like, why now? Like, I'm not sure how old the stroke was, but like, why would this cause a seizure all of a sudden? But I think your hypothesis about the contrast causing this, I hadn't heard of that, but that makes logical sense to me. And so I guess the idea is that it improved because the contrast just got washed out. Is that the idea? Okay.
Yeah, that's what happens to people. Yeah, she could have had another stroke. Very possible. So in real life, I wonder how far you take this case. Do you get an MRI just to be sure, or do you say she's better, so I'm done? I actually don't know the answer to that. Yeah.
All right, Jazz, what happened?
So you guys were awesome. I've watched VMR so many times and I feel like, it's always so hard to be on the presenter side. And I have a feeling that I could have definitely presented this better, but you guys still did a masterful discussion on what I presented to you guys. So someone asked about the official read, and that will obviously give away the answer. So marked hyperdensity within the ventricles, subarachnoid spaces, extra axial spaces, as well as visualized spinal canal, likely representing contrast refluxing superiorly from a recent myelogram. It was exactly what you guys talked about possibly being contrast-induced encephalopathy and also contrast-induced seizure. Neurology was very convinced that the contrast that was used in the myelogram was kind of irritating the the brain parenchyma that would lead to a seizure-like activity, which is why initially because there was just so much contrast that was going into the brain or into the ventricles, that the Ativan wasn't really helping, and it had to go they had to go up to the phenobarb. But also, obviously, in that case, patient was in status epilepticus, and you don't want to wait. But theory is, if we kept giving Ativan, maybe she could have gotten better. But I'm glad they did the phenobarb. And then when she was put on the Keppra, she did started to improve pretty quickly, which is what neurology was like. Okay, that makes some sense that this might be contrast-induced encephalopathy and seizures. They did get an MRI just to be like exactly what you guys said. You don't want to miss a stroke because of her history, and you don't want to miss other things. But the MRI basically was consistent with her MRI in 2015. And 6 months ago, 2 years ago, which so 2015 was her last stroke, and 2 years ago there was a concern for a TIA. So those are the previous MRIs to compare it to, and they were basically normal. I wanted to present this case because I never heard of contrast-induced encephalopathy or seizures, and I kind of felt like this was something would be a great case. And then the other thing is now. The next question that I asked was why her? Like, there's myelograms that happen all the time. Why did she get contrast-induced encephalopathy and not, some other individual? And I had a brief discussion with one of the neurologists, and we're thinking about maybe writing this up. But her pseudotumor cerebri, or intracranial hypertension, was one of the reasons why she had the CSF leak. And there's theories that over time that can lead to the breakdown of the blood-brain barrier. And is it possible that was a potential risk factor? I honestly don't know the answer to that. Rabih, if you or anyone here knows that if that is a possible risk factor, that is great. But that is one of the things that might have been put at her risk, but she did have that history of a CSF leak. That's all I had.
Absolutely.
Yeah.
Go ahead, Meg, please.
No, I was just going to say, the question I was about to ask you is if you knew, like, who does this happen to? Because exactly as you said, a lot of people get these procedures. So why did this happen to her? So I think that was just really amazing teaching. And the fact that there could potentially been a breakdown in the blood-brain barrier, kind of putting this patient more at risk is that I just thank you for kind of like following up on that and giving that teaching point, because that was something I was curious about. And I think this presentation was really fantastic and made for a wonderful discussion and learning experience for me. So thank you so much for stepping up to present it.
I have a favor to ask of everybody here is, can you please, on a scale of 1 to 10, tell Jazz how amazing this case was? Please, please, please. Because I have no idea. I'm actually utterly clueless as to why you kept over and over and over saying that you could have done a better job presenting this case. I think that's something for all of us to reflect on, how the culture within medicine changes perception from reality. And I think that your perception of how you were doing is very much something that, wow, Yasmin is really good with her exponentials there. I think the perception and reality in medicine is something that we should really, that all of us reflect on. And I think that I'm so glad that you said all this and brought it here, because I think that's probably how most people feel, and I think it really is when you stand in front of the mirror of case presenting, and you do it over and over again, maybe like 3 or 4 times, do you realize, actually, no, I'm doing a good job at this. I'm doing a really, really good job. And so I'm really glad that you pushed yourself to present despite feeling that way. I think that is so powerful and so telling. And hopefully a small part of your brain will incorporate the feedback that the crowd is giving you today to get you closer and closer to the true impact that it has on us. So thank you. I think we learned a lot today. Learned a lot about some very practical things like seizures and altered mental status and some esoteric things. But I think a most powerful lesson is watching somebody who is vocal about the challenges that they're facing presenting a case publicly, but is doing it nonetheless. And now, as the crowd has demonstrated hands down, did so brilliantly. So thank you. Really, really appreciate it.
You're all so kind, really, truly. But what I do want to say, both Maddie and Robbie, you guys did a fantastic job. The radiologist and the neurologist were a little bit perplexed initially, but you guys were on it right from the beginning that this may be is associated to the myelogram.
Amazing. Maddie, how'd you feel? That's a tricky one.
Yeah, this was a very tricky one. You know, I think I had the last case we discussed, actually also the chief concern was seizure. And I found myself in the last one just so like, oh my gosh, how do I even think about a seizure? So I had, you know, I felt a little bit more structured about how to present a seizure, but it's still a very intimidating topic for me to think through. It's a little bit confusing for me. So I just really appreciate all of these opportunities to discuss and think through them. And I think something that will be like a big warning point for me is how I think a turning point in this is like how the proximity to the recent procedure, but then also how the patient improved on Keppra. So I think I want to, I guess you can make progress in the differential by like the response to treatment or not. So that's something I want to go back to. But overall, yeah, seizure is just a really challenging topic, but I just always really appreciate these opportunities to practice discussing. And I hadn't heard of this diagnosis before, so the whole point of this is just to learn. And thank you again, Jazz, for presenting.
Yeah, no, Maddie, I think it's seizure are really, really tricky in real life because the ultimate reason can be, oh, you've had a scar in your brain for 30 years and you happen to seize today just out of bad luck, or that you have bacterial meningitis and that's why you're seizing. It literally could be a sequelae of something 30 years ago or one of the most deadly diagnoses. And so it's very hard in real life too. But the more reps you get in practicing, the more comfortable you'll be in these very tricky situations. All right, well, coming to you live from the icy cold, recently moved Deborah from Charlottesville. You want to take us home with the teaching points, my friend?
Yeah. Hi, everyone. Thank you for the case. It was such a great case and great discussion, Rabih and Madalena. So going for the teaching points. The patient presented with the generalized tonic-clonic seizure. So we think about the VMRs. It could be like a transient loss of consciousness or a syncope, a stroke, a hypoglycemia. And we need to check like other additional symptoms. How is the tongue of the patient, if had focal neurologic deficit, and how was the patient before and after the seizure. And then we discuss about the CSF leak complications that could be infections, herniation, Crohn's, in the contrast encephalopathy. And I never heard about this diagnosis, so I did a little bit of a Google it. And it's a rare complication and can manifest with headache, cortical blindness, conscientious disorder, seizure. And normally the symptoms are transient. And in this case, we thought about that the patient could have because of the intracranial hypertension that caused the CSF leak and could be a potential risk. And the contrast can induce not just the encephalopathy, but then the seizure too. And we had a mnemonic for the CT scanning of the brain that we look for B blonde, C cisterns, B brain, B ventricles, and B bones. So to help us to check the next CT of the brain that we have. So thank you, everyone. I hope to see you all tomorrow.
Absolutely amazing. Wow. Thank you so much, Deborah, for such a concise recap. Thank you again, Jazz. Thanks, Maddie. Hope to see you guys next time, which is tomorrow.
Bye.
Bye.
Bye.